This video is a demonstration of ankle mobilization manual treatment. For ankle mobilization, so we focus on the talocrural joint. Talocrural joint is mainly for dorsiflexion and plantar flexion. When the patient have inadequate dorsiflexion, assume its joint problem is mainly after joint sprain, ankle anterior impingement, then it's stuck in the joint, then we have decrease in the ankle dorsiflexion. You can ask the patient to do a deep normal movement or do a deep squat, then to see whether there's some stiffness or decrease in range of motion. Then to increase it, if it is a pure joint movement, we can do the Mason post anterior posterior mobilization. Anterior refer to the talus bone. So the wedge of the hand can grab just below the talocrural joint line. The other hand put below the calf. Then you can support by your thigh, can do some anterior posterior translation to mobilize it. And then if this is improving well, you go to the restricted angle to do it. Sometimes if we cannot do all the way dorsiflexion, we can ask the patient to bend the knee. We can do it this way. It's even easier. Okay. Then for decrease in plantar flexion is totally opposite. Then we do the posterior anterior mobilization. Usually the typical way we go to prone lying position, but for some time of convenience and for the patient that they cannot lie down facing down, we can also do it this way, is that also bend the knee. The right hand support the lower part of the tibial bone, stabilize it, then the other hand do a forward pulling. This is also a modified version of PA mobilization. But also bear in mind that high ankle sprain very often involve the joint is the inferior tibiofibular joint, because there's a strong ATFL ligament will pull the joint forward. Then to observe any swelling here, and also we'll see any tenderness there. Because it's being pulled forward, then when we do the mobilization, we do it backward. People with this problem will also have difficulty in end of range dorsiflexion. Okay, so we can use, if small tiny ankle, we can use our thumb to do the mobilization, AP mobilization. If for the big ankle, then we can use the thinner side. We can do it this way instead. Then for decrease in ankle inversion, eversion is rather less common in talocrural joint, but also the subtalar joint. In the subtalar joint, there is the subtalar joint bone, including the navicular, tricuneiform, and cuboid bone. Can check whether it's decrease in inversion, then we check the medial side, or decrease in the eversion, then we check the lateral side, the subtalar joint. Then the mobilization is very simple, but for people with strong thumb, we can also do it this way, is a PA mobilization. Because when doing the spring, usually the joint is come downward, so we go upward to do a PA. If the people, the thumb is not that strong, they need to use some massage tool, okay, to do the mobilization instead. Or if you have the tennis ball, just a second. Ideally, with a golf ball, you can ask the patient in sitting position to step on the ball and do some active rolling massage. This is a rather self-mobilization at home, then can loosen the target subtalar joint bone. Those are the revision of mobilization techniques for the ankle and foot.